Okay, so hi everyone. We're gonna go over some freestyle teaching today. So the first thing I want to do is go back to basics, actually. I think it's a good idea to always go back to basics and try to understand the different cardiac chamber. And I was actually working on kind of putting the info into this figure. So I want to spend a bit of time and go back with the normal heart and speak about pressures, saturations, and flows. Okay. So, Saria, what will typically determine a pressure?
The flow and resistance.
Exactly. So typically, it's a pressure is driven by how much flow there is through a structure, and typically how much resistance there is within this structure. So if, for example, the RV is not contracting, or you have a dead RV, so the pump does
Mm-hmm.
not work, you're not able to generate flow. And because you're not
Mm-hmm.
generating flow, you have no pressure. Does that
Mm-hmm.
make sense? So,
Yes.
example, you can have very, very high resistance in a circuit. Like, let's say all the vessels are completely closed, completely obliterated. Okay, they're super, super, super tight. If your RV is dead and not contracting, and you go and you put a catheter in your pulmonary artery and you measure the pressure is going to be zero because there's no flow.
Mm.
But the resistance downstream can be very, very high.
Mm-hmm.
Does that make sense? The resistance
Yeah.
is very high. So if I would generate flow, there would be a very high resistance to this flow. So it's important to keep these concepts in mind when we're assessing some of the patients. And that's the typical case of like functional pulmonary stenosis or functional pulmonary atresia, is that often they have extremely high PVR. The RV is so impacted and so dead that it's not able to generate forward flow. And because of that, there's absolutely no pressure in the pulmonary artery, and often you have a duct that's going to be left to right, which sounds counterintuitive, but it's because there's just no pressure being generated in the pulmonary artery. So you get
Mm-hmm.
you get this left to right shunt, but actually it's because it doesn't mean you have low PVR. You have still very high PVR. But because the RV is not generating any forward flow, you don't get any pressure generated in your pulmonary artery. Does that make
Mm-hmm.
sense? Okay,
Yeah.
perfect. So we're going to go over the diagram and we're going to talk about different concepts of pressure curves and things like that. Um, I will just go here and bring you to the page of physiology. So if you go in the physiology, there's many physiological concepts that you need to grasp and understand. And sometimes they can be very dry, but when you put them together, it makes a lot of sense. So just for you, Laurence, who will be starting in July, this is like kind of the basics. It's like, kind of understanding pressure, resistance, flows. What are the different chambers? How do they interact together? What is afterload? What is preload? What is contractility? And then we dig into deeper concepts because we are made of a pulsatile pump, actually two pulsatile pump, big pumps. Plus, we have contractile reservoirs, which are the atriums. We need to understand the different pressure loops of these different chambers and how do they interact together, and how there's interaction between, for example, the right and left atrium, because our babies have shunts, for example, between the atriums, but they also share a wall that is mobile, which will also influence these kinds of pressure curves. Um, and on top of this beauty is that we also need an activation. So there's always like, what does the QRS activity mean relative to your atrial contraction, relative to your ventricular contraction, relative to the motion of the valves? And so we know that the P wave will trigger an atrial contraction, et cetera, et cetera. So if I go down, so there's many concepts to go over. Yeah. Saria, did you see something?
No.
No? Okay. So we just mentioned that a pressure is typically a flow times a resistance. And there's obviously a component within so there's the resistance of the actual circuit, but then there's the downstream element that will be also an extra pressure under which the system needs to drain into. So obviously, for example, for the pulmonary vasculature, you have the left atrial pressure towards the end of this circuit. And so you have the output of the right ventricle times the resistance of the pulmonary vasculature. And then you have the venous pressure downstream, which is the kind of LA pressure reservoir that is basically the downstream of your pulmonary venous return. And so that left atrial pressure will be influenced by various factors. Can you name some of these factors that will influence left atrial pressure? Like, why would a left atrial pressure be high or low? So, for example, what could rise left atrial pressure?
Like if we have severe MR, that the blood
So
is
severe
flowing
MR.
back and it
Yeah.
creates high pressure.
So mitral insufficiency that is very significant, which implies when you have mitral insufficiency, if there's a big volume of blood leaving the left ventricle and going backwards into the left atrium, it means that there might be a significant portion of your ejection fraction that actually is going backward. So sometimes we have situation where if there is significant MR or TR on the RV side, and you see that the RV is contracting very well, it might not mean that this RV is generating sufficient forward flow. Maybe it's actually contracting very well because it's contracting against absolutely no afterload. So it's very easy for an RV to pump backward into a right atrium that is of very low pressure. So it's not a chamber that it's hard to pump against. Okay, so we see that, for example, in patients with severe Epstein's anomaly, where they have this very abnormal tricuspid valve, and sometimes they can have extremely severe tricuspid insufficiency. And because of that, they get a massive right atrial dilatation. And actually, these patients may have very poor RV output. It may be a lesion that is ductal dependent and needs that left to right shunt to actually provide blood flow to the lungs, because there's almost no RV forward output into the RV outflow tract and into the pulmonary artery. So if you go here on Epstein anomaly, this is kind of a classic. You see this atrium that is kind of massive, and you see this TR that goes up to the roof of the atrium. So these patients typically have very, boggy right atriums because they've been exposed during fetal life to a very abnormal Epsteinoid valve that tends to leak a lot. This RV is usually smaller because there's atrialization of the ventricle wall, of the actual muscle of the ventricle. So there's an implantation of the tricuspid valve that is very low. Now, we know that in normal anatomy, if I go in here, we know that the tricuspid valve is normally implanted more inferiorly compared to the mitral valve, which is a bit more superior, right? So we always have the tricuspid valve that is a bit lower than the mitral valve in the heart, and we always have a little component of the septum which is shared between the right atrium and the left ventricle. We call this the atrioventricular septum. It's very tiny. The only time where you don't have these valves on a different plane is, well, the only time, one of the most common time where you don't have these valves on the same plane is in the AV canal. And at that point, it's not really a tricuspid or a mitral valve. We call this an atrioventricular valve. And this atrioventricular valve may have various configuration of different leaflets that are kind of used by the surgeon to eventually septate and recreate a left and a right atrioventricular valve. But in the AV canal, this atrioventricular valve is kind of on the same plane. But in normal anatomy, the tricuspid valve is always displaced more inferiorly compared to the mitral valve, which is a bit higher. So you can see here, the plane of the mitral valve is here, and the plane of the tricuspid valve is kind of here. So they're not exactly on the same plane. And because of that, there is a little portion of this wall that is shared between the right atrium and the left ventricle. And if there is a hole in that part of the septum, how do we call this ventricular septal defect?
Body.
Gerbode
Gerbode.
defect.
Yeah.
Yeah, Gerbode. So it means that if it's large enough and if it lets volume and pressure, enough volume and enough pressure to be shunted inside the left atrium, your left atrium can become your right atrium. In your right atrium, so the LV to the RA, your RA can become really big, actually. You can be exposed to, suddenly your right atrium is going to be exposed to whatever the LV is generating in systole to generate blood flow into the outflow tract of the aorta. So we call this a Gerbode defect. So if I go back to Epstein's anomalies, they get a lot of this, some of these patients, they get a lot of TR, and because of that, they don't get forward flow into their RV outflow tract. Do you know what's the circular shunt physiology? Have you ever heard of that? The circle of death or the circular shunt physiology?
No.
No one? Oh, I think Dr. Angelica Vasquez spoke about it in her recent amazing talk on congenital heart defect for NHRC. So if you have not listened to that, I don't know if you were on vacation. I think you were off on vacation, Surya, but this talk is absolutely superb. She goes over the different physiologies of congenital heart defect, and she shared her slide with us. And it's an absolutely fantastic presentation. She goes over the different saturations and the different chambers, the balance between pulmonary and systemic blood flow, and she navigates through different physiologies. So I strongly recommend you go over that because it actually provides you with a lot of core concepts. Because when you start understanding these different variants, it helps you put together what you need to do for patients with normal hearts that have functional issues. Because you understand shunt physiologies, you understand the balance between pressure and resistance, etc. So in her talk, I think, did she go over, she went over the circular shunt, but not in the talk, but in the case presentation. So what is the circular shunt? I'm gonna go here. I think I put a picture here, circular shunt. Okay, is there in this article? No, not this one. In this article, maybe, no. And then, let me see, outside article. Yeah, so there's a lot of resources when you see like the implantation of tricuspid valve, which is very low, and the atrialization of the RV, that's what ARV means, your atrialization of the right ventricle. So your RV becomes less, the capacitance is diminished. Okay, it's not here. So I'm going to use this diagram. What you have in a circular shunt physiology, which is like extremely, the worst nightmare of everyone, is that you have the combination of extreme pulmonary valvular insufficiency and extreme tricuspid valvular insufficiency. So you can decrease pulmonary blood flow or effective output in your RVOT when you have significant pulmonary valvular insufficiency. Similarly, on the left ventricular side, you can diminish dramatically your left ventricular output if you have significant aortic valvular insufficiency or a steal from somewhere. Like, for example, an aorta to ventricular tunnel, which is something that can seal inside the left ventricle. So your functional output to the system drops because things are going backward. Make sense? So in the circular shunt physiology, what happens is that because you have significant pulmonary valvular insufficiency and you have significant tricuspid valvular insufficiency, the RV contracts. A lot of the effective output of the RV goes backward into the right atrium. This crosses to the left atrium because the RA pressure becomes extremely high compared to the LA pressure, okay? The LA empties into the LV empties into the aorta, And because you have very low pulmonary blood flow and steal from your PA to your RV by pulmonary insufficiency, your PDA will feed blood flow into your pulmonary artery because the pulmonary artery is relatively empty because there's just no forward flow. And this blood flow is going to go where? Instead of going to the pulmonary artery, it's going to draw back into your RV and redo this beautiful circle. So we call this a circular shunt physiology, or some people call it the circle of death. Why? Because if you go like this for a while, well, you're going to die eventually. The reason you have a favored shunt from right to left, well, first of all, it's because you have high RA pressure because your right atrium is basically facing torrential flow coming back from the RV. But also because your left atrial pressure becomes very low because the left atrial pressure is dependent on pulmonary venous return. And I just told you that the blood flow who's supposed to go to the lung, first of all, you just don't have much output from this RV because this RV is very tiny and most of its content went backward into the right atrium and did not go forward. So the PA is just not being filled nicely by your RV who's relatively abnormal and not providing enough forward output. But also, so you have less blood flow going forward, and whatever is coming through the PDA is just going backward into the RV and not really going forward into the pulmonary arteries, which means that your pulmonary vasculature is underfilled. And what does this create? Well, it creates a sequence of hypoxia, of acidosis, of adrenergic surge, where suddenly your adrenals are releasing tons of these different mediators like adrenaline, noradrenaline, dopamine precursors, things like that, that are, boosting to increase the cardiac output because it's sensing ischemia. So you develop, lactic acidosis, low pH, and all of these factors are just worsening the situation because, first of all, your pulmonary vasculature is sensing less blood flow. So a system that is sensing less blood flow and is trying to maintain a perfusing pressure is going to do what? It's going to react by vasoconstricting to maintain the perfusion pressure. It's true for the lungs as well. Your oxygen in your blood content is going to progressively decrease and decrease and decrease because there's less oxygen going to the organs. And if there's less oxygen going to the organs, whatever the organ are sensing, they're extracting more and more. So your saturation keeps on coming back to the SVC and IVC lower because the organs keep on extracting as much oxygen as is available and residual in this tissue. So maybe you start at 60%, but then it comes out back at 50, and then at 40, and then at 30, and then at 20, and then obviously you pass away. So you get pulmonary vasoconstriction because of the effect of the flow being reduced. You get further pulmonary vasoconstriction because you're hypoxic. We know that oxygen is a pulmonary vasodilator. And you get further pulmonary vasoconstriction because you have this acidosis, catecholamine surge, and all these things. And the PVR increasing worsens the circular shunt because suddenly it's much harder for the PDA shunt. Why would it go this way when the PVR is so high, when it's so easy to just go into the RV when the RV is relaxing? So think about this structure, which is a muscular pump that contracts and eventually relaxes. When it relaxes, we know that these ventricles, the pressure drops a lot, right? It's like a suction effect. So it's going to be very easy for the pulmonary artery, if there's significant pulmonary insufficiency, to actually just go back down. So this circular shunt gets worse as the patient is worsening. So what are things you could do to block this terrible cycle? Which is not an easy cycle to break.
Will it help if we increase the contractility of the RV?
Yeah, you can try to support a bit the RV, which is already a tiny RV. Sure, the baby's going to be acidotic at this point, so probably if you're there, you probably will want to have some support to your cardiac function regardless, because acidosis is never very good and coronary hypoperfusion and ischemia is never very good. So you might decide to give a bit of epi support to support the RV. You always have to be careful, because then these patients they're already very tachycardic. So you have to be careful to make them not even more tachycardic. And then, if you increase tachycardia, you increase oxygen consumption, and then your muscle needs even more oxygen. So you're increasing oxygen demand of the myocardium. So it's these things you have to be careful. The other thing you have to remember, that the right atrial pressure is very high in these patients. And if it's very high, the right atrial pressure, it means the coronary sinus, which is where your coronary arteries are emptying, is facing this very high right atrial pressure. Most of the time, I think, don't quote me on that, I'm not a morphologist, but I think 90% of the coronary systems will tend to drain via coronary sinus, or close to 95%, but I know there are variants. And so if your coronary system is emptying into right atrium that has a central venous pressure of like 11, 12, 15, 20, very, very high right atrial pressure, and you have very low diastolic pressure because you're emptying everything in your PA, then obviously you could be at risk of, having some degree of coronary ischemia, especially if your oxygen content is very low. So these patients are very sick. They're probably going to need a bit of, support, inotropy, but you have to be careful too. Sometimes some of these patients are they're already very adrenergic, so they're already very clamped. In general, when you have low diastolic pressure, you do like to have a bit of SVR effect. But I don't think in this context I would put like norepi or vaso, because these patients can have, concerning responses to that, because the LV might be struggling for all of these reasons. So it's typically more going to be a low dose epi to support your function, your output, have some SVR effect to promote a bit of a higher diastolic pressure in your aorta in order to promote coronary blood flow. But that's really not going to change your circle of death. It's not going to change your circular physiology. So what would be potential strategy? I told you that a lot of it comes from the fact that you have blood flow that is being stolen and goes back into your RV. So this blood flow sometimes is torrential. So if the PDA is large, you just steal and steal and steal and steal and steal, and nothing is going to your system. So that's definitely something of a problem. And I told you your PVRs are very high for all of the reasons I mentioned, which also worsens this pulmonary insufficiency. So what are the things you could target to try to address this?
Drop PVR, maybe like start with INO to help.
INO, so you can try to drop your PVR. So obviously you're going to intubate, mechanically ventilate this patient because you want to decrease cardiac work. You want to maximize your pulmonary venous oxygenation. You want to try to decrease the PVR because these PVR are competing for the flow through the pulmonary arteries. So these are patients you're going to consider putting on INO, putting on oxygen, addressing their metabolic demand. So you might sedate them. So low dose fentanyl, and really to try to keep them calm and avoiding oxygen needs. Obviously, they're NPO, right? Like you're not going to start feeding these patients when they have a very high metabolic demand and are very catecholamine activated. Do you want to keep the PDA open? Do you want to keep the PDA open? That's the question.
If we close it.
So, this is a beautiful graph. There you go. It even put the X for us. So that's, I don't really treat ducts in general, but that's one of the situations in which you want this PDA to restrict. And actually we sometimes, if we anticipate that there might be a circular physiology, if there's already significant pulmonary insufficiency in fetal life, so sometimes in fetal life they're able already to see that there's pulmonary insufficiency, they may even give NSAIDs to the mother. antenatally to do transplacental treatment. So these patients, we're gonna either, depending on the degree of severity, we may either give NSAIDs or sometimes they even go for straight ligation to close it. Because if you close this, then you don't have this steal. And so what happens is that, yes, you get a to and fro flow into your PA, but at least you're able to maintain systemic output and you have less contribution of direct flow coming back towards the pulmonary valve. Because that's one thing about the PDA in this particular patient situation is that the flow of the PDA goes straight down through the pulmonary valve. So it kind of, it encourages this leaflet of, insufficiency. So in some of these patients, that would be kind of your initial management, but they can be very sick. It's a high rate of mortality. Some of these patients may need to go on ECMO very quickly, but they're not easy to deal with because of these valvular insufficiencies. So it can become also very technically challenging to give, to support them on bypass or ECMO. And so many of them will go for urgent surgeries. And they're obviously, they end up with single ventricular physiologies most of the time because of the degree of the severity of the disease. So that's just to bring you back to the concept that it's just to talk about the fact that mitral or tricuspid or atrioventricular valvular insufficiency can create a lot of flow and pressure being transmitted at the atrial level and competes with the flow that is supposed to empty into the outflow tracts. Does that make sense? So there's less flow if the LV contracts against a left atrium and brings back flow into the left atrium. It means that this flow that is going towards the left atrium is not going to the aorta. Okay. So let's go back. What will influence pressure in the left atrium or right atrium? It's typically the preload. Okay, so how much preload is coming to that atrium? So on the left atrial side, if it's a normal anatomy with normal pulmonary venous return, the left atrial preload is dependent typically on your pulmonary venous return, which is dependent on your pulmonary vascular perfusion. It is sometimes also dependent on what's happening in terms of the dynamic at the foramen ovale. So if you have a small hole versus a big hole, and you have small amount of volume entering from the right atrium to the left atrium, or big amount of volume going from the right atrium to the left atrium, well, that may also influence your left atrial pressure because you get flow coming back from your right atrium. So think about a situation where you have a patient who has a significant pulmonary hypertension crisis and has no duct. So suddenly the PVR goes very tight. Your RV suddenly faces significant afterload. It has nowhere to decompress. You may have acute RV failure. So the RV may dilate a lot because it's not able to cope against this afterload. So think about you going to the gym and trying to take a bench press of like 600 pounds suddenly. It's just gonna fail, right? If you train for it maybe one day, although 600 pounds is a lot of weight, but so you're just gonna fail. And the flow coming back from the IVC and SVC is gonna have nowhere to go because the RV is like this balloon that is already completely filled. So your tricuspid valve will just create a lot of insufficiency and your RE pressure will start rising. So if you do have a hole, like a foramen ovale, if it's very tiny and the RE pressure starts rising, it may send some blood flow to your left atrium. If there's no hole, it's not going to send anything. So the backflow is just going to go into your SVC and your IVC. So on echo, you're going to see a lot of retrograde flow in your subhepatic veins and your IVC, sometimes even in the SVC, and then your liver is going to start to become very big. Okay. And when you have this situation, these patients become very, very, very low in their LE preload. So their actual left atrial pressure is very low. It's like 2 millimeters of mercury. It's almost empty. It's like the balloon deflates. There's just nothing in it because you have high PVR, no pulmonary vascular perfusion, no pulmonary blood flow, and almost nothing coming back via your pulmonary veins, and you don't have an interatrial shunt to feed flow into your left atrium. So what's going to happen? Your LE pressure is going to go down. Your LV is going to have very, very low preload. So eventually it's going to try to pump whatever it has, but it's not going to be able to effectively generate sufficient cardiac output. And these patients, they die from low cardiac output syndrome. They die very gray. They're very poorly perfused. They're satting very well. They're satting like 98, but who cares? They have like two little RBCs that are satting at 98 and walking around and trying to bring oxygen to tissues. And these patients are dying. Depending on your size of your ASD or PFO or interatrial shunt, if it's very tiny, your patient may be slightly desaturated, like 92, 90, because there's a bit of blue blood entering there, but it's still very insufficient. And if you have a huge ASD or a bigger ASD or something that allows more volume to empty into the left atrium, then at this point, your LA being nicely filled, which will fill nicely your LV, which will be able to generate output. So these patients will be able to generate output, but they'll be extremely blue because the saturation here, which let's say you start at 60, you're going to send here, which the stat is 98. Maybe you have 2-3 RBCs coming back. But if you have 2,000 RBCs that are going through and you have 3 RBCs that are coming back, well, that gives you an average of probably 63%. So then you have 63%, then you have 63%, 63%. And then what's going to happen? Your organ are going to consume oxygen. Let's say they consume 15% or 20%. So instead of 63, suddenly you're at 43. So you're coming back here at 43. Same thing, you're at 43, you go through. Now you have 2-3 RBCs coming back at 100, 43 plus your 2-3 RBC, maybe you're at 46. Same cycle. And eventually the problem is that you end up not having enough oxygen in your system, and then you're going to go into tissue ischemia and hypoxia. So you have to find a way in the meantime to really improve your pulmonary blood flow by giving pulmonary vasodilators, INO, oxygen, appropriate mechanical ventilation, recruitment of the lungs, all these things. And sometimes that's not enough and you have to go on ECMO. And that's why in these patients, you can be able sometimes to go on VV ECMO to just oxygenate the blood that comes here and bring oxygen here, which eventually oxygenates the pulmonary vasculature and brings back oxygen via the pulmonary venous return. So you're able to expose the vasculature to a bit of oxygen through the pulmonary vascular bed, which is going to help vasodilation by this mechanism. But at least you know that you get blood flow coming back to your LA that is satting at least 90 or 92 through your VV circuit. Okay, so atrial pressure are influenced by their preload. They also have a component of contraction. So if you go back to the physiology section, you're going to see that, there's different waves. And typically your left atrial pressure after 1 or 2 weeks of life is a bit higher than your right atrial pressure. And you see that these waves correspond to different moments of the cardiac cycle. And this is different in the right and the left atrium because, the right atrium typically will face a tricuspid valve and RV, and left atrium will typically face a mitral valve and an LV. So you get a component of atrial contraction, which faces the P wave, or usually the P wave is supposed to be slightly before. So you have atrial contraction, and then you have a component of ventricular motion. So obviously, after the atrial contraction, the pressure will drop slightly, closure of the mitral valve or closure of the tricuspid valve, which suddenly will increase slightly the pressure into the atrium just because you close and you still have blood flow coming back from your pulmonary veins or from your SVC, IVC, which fills your little balloon, which has a closed door. So the pressure will rise a bit because there's still flow coming inside. And eventually your ventricle will contract. And when the ventricle will contract, you get a bulge of this mitral valve or a bulge of this tricuspid valve inside the atrium, which is still being filled, right? So the pressure will rise a bit. So we call this the V wave. And then you get mitral valve opening or tricuspid valve opening. So the pressure will drop because everything empties into your ventricle. So as soon as the door opens, the flow empties until your pressure drops. And same thing, you get your atrial contraction, et cetera, et cetera. So we know that this portion of the cardiac cycle is the ventricular diastole, which means it's the period of filling of the ventricle when you get a portion which is the emptying of the atrium into the ventricle when the mitral valve or the tricuspid valve will open. And eventually you get your little atrial contraction, which also is a period of ventricular diastole. Then you get closure. Then your valve, the atrial contraction has emptied completely. And then you get a drop of pressure and suddenly the valve closes and you get a re-increase of pressure. But throughout this entire time, if you look at the pulmonary velocities, this is normal echo, crab view. If you look at, how these look like, you get a sense of the flow coming back from the pulmonary veins into your atrium. It's continuous. You always get flow coming back through a vein. So the left atrium is consistently being filled by whatever's coming back from the lungs, right? So it's never like there's a moment it's getting filled in and there's nothing coming, because there's no valves closing completely the veins. They have little valves typically in the leg veins, but it's not like a door that's preventing blood flow. Okay, so that's the concept of atrial pressure. So we spoke about the fact that it's dependent on preload, it's dependent on the atrial contraction, it's dependent also on ventricular interactions with atrium. So we spoke about the fact when the mitral valve will close, when the ventricle contracts, it creates these undulation on the actual atrial pressure curve. And it is influenced by foramen shunting. So for example, if you have a lot of pulmonary blood flow, huge PDA left to right, huge VSD left to right, truncus arteriosus with a lot of pulmonary blood flow, anything that will create these over circulation, well, your pulmonary venous return is going to be significant, right? So that will increase a bit your left atrial pressure, which eventually will create this left atrial dilatation. If you have a very, very tiny PFO, there's part of it that's going to go towards the right atrium. But if you have a very large ASD, then you're going to decompress your LA. So your left atrium pressure may not rise that much, and it may not dilate that much because you have a pop-off to this atrium. Okay, so that's why when we look at these ratios by echo, like LA on aorta and some of these other markers of dilatation, even pulmonary venous dilatation or RA dilatation, all these things, you always have to think, where is the flow from the right atrium going? Is there even an opportunity for this sac to kind of dilate if there's a pop-off to this pressure buildup? Because things won't dilate if there's not pressure buildup typically, unless there's like excessive flow. Like vein of Galen will typically dilate a bit your SVC because the SVC has a certain degree of capacitance, right? It's a floppy vessel, but at some point, the more you're going to open, you're going to crank up the tank. If you put Niagara Fall through an SVC, it's going to dilate because there's a capacity to which it can contain that much flow. Okay. And then there's obviously the atrioventricular valve health. So if you have a lot of insufficiency or if you have stenosis or a blockage, so think about situation like rheumatic fever, endocarditis, mitral valve stenosis secondary to an anomaly of the mitral valve. So all these patients with small left ventricles, mitral valve, parachute mitral valves. We often see that in Schoen complex. So have you heard of Schoen complex, Surya? You have? Perfect. So you should read about it just to be aware of what is this entity, Schoen syndrome. It's typically a situation in which you have smaller LV, you have a parachute mitral valve, and sometimes they can have some degree of mitral stenosis. So it's really a condition of anomaly of the left-sided cavities. And it could mimic to some degree hypoplastic left heart syndrome in certain situations. Okay, so it's important to be aware. Some Schoen syndrome, Schoen complex are not so bad. They can have quark, they can have interrupted aortic arch. So it's really a disease of all the left side of the heart. Okay. So that's for atrial pressure. And then, so we just spoke about atrial pressure and, pump and venous return. What I would like you to go read on is understand a bit more the mechanics of pressure and saturations at the level of the ventricular levels. So you're going to go into the physiology section. And one thing that should be like by heart are the pressure volume loops. Let me go here. So you know the pressure volume loops, like at the different stage of the cardiac cycle, you get ejection filling, and what's the relationship between pressure and volume. This is, I didn't put specifically for the RV or the LV because it's pretty much the same, but you have a filling period. At the end of the filling period, you get atrial valve closure, and then you start having your ideal volumetric contraction. And eventually the contraction will lead to pressure buildup in the cavity that will exceed the pressure that is residual in whatever vessel the ventricle is connected with. And that will allow the valve at the level of the outflow tract to open. Okay. So whenever this is an example of the left side. So whenever you start your LV contraction, you have to reach a portion where the pressure that is being built up inside the ventricle is higher than whatever diastolic pressure is residual in the aorta, and this will allow the aortic valve to open. So you can think of a patient who has very low diastolic pressure, well, your LV will open the valve earlier. If you have a very high diastolic pressure, like a hypertensive patient, or a patient who has like significantly high SVR, if your LV is already struggling to generate pressure, the amount of pressure it needs to generate before it can open the aortic valve might be higher. And the time you spend in injection may be shorter because of that. So you have to take these into account when you look at these pressure time curve. And so here, you have the pressure that is being generated, and here you have the volumes that are being generated, and you have here the P, the Q, the R, the S, the T waves that represents the activation, the electrical activation. So it's important to understand these pressure loops, because if you would go in the cath lab and put your catheter in the ascending aorta, that's basically the loop you would be measuring with a dichrotic notch, okay, because you get closure of your valve, so suddenly your vessel, your pressure drops a bit, and then you get a rebound from the compliance of the system, and then you start having a drop of pressure progressively as you get forward flow inside your tissues, and eventually, boom, you get a re-ejection of blood flow, which re-increases your peak pressure. So you have a systolic pressure, and the lowest is a diastolic pressure. And that's the two measurements that we do. But really, if you do an area under the curve of this red line, it's what we call the mean pressure, right? And it's important to understand these different curves. But you can see the left ventricle, its pressure gets near zero, like 0 to 5 millimeters of mercury. And you remember two structures that are connected will equalize pressure. So when the mitral valve opens, that's when you get this LV and diastolic pressure being the same as the LA pressure. So I see it's 10:53 and you have an echo in 7 minutes. I think for today, the key concept is to try to go back to physiology and understand each chamber, where is flow being generated, where flow can be decompressed. And when there are shunts and interconnection, this blood flow that is being crossing to another side may influence the saturation levels. Make sense? Saturation in the venous compartment is typically driven by the metabolic demand. And so if that's what we try to estimate or guesstimate when we put NIRS sensors, is to have a sense of what's the venous weighted oxygen saturation at the tissue. And you know that this can be influenced by many things. One of the things is how much blood flow is passing through this tissue. The other thing is how much the tissue is extracting. So if you're seizing, for example, you're going to extract even more, and your SVC saturation will drop. Okay, so that's for today's kind of review of basic pressure cardiac curve physiology. Sorry, I do think you need to go through the physiology section one by one and look at all of these concepts, take notes, review, make sure they're crystal clear for you and that you're able to apply them when you look at like different hearts. Because when we do echo, what we're trying is actually to get this info. Part of it is to get this info. Where's blood flow going? How much output is being generated? Where's my PRBC going? Is it going forward or is it going backward? So that's why I highly encourage you, when you see patients with hemodynamics concern, you know, obviously now we do the echo, we discuss the management, but I think after, when you're doing your report and you're actually putting together all the pieces, that's not what I wanted to show. I wanted to go here and I wanted to go into TN echo protocol. I highly encourage you take this graph and you actually draw the saturations, the blood pressure, you know, the blood pressure in the aorta, you know, the flow through, if there's a duct or no duct, so you can print it and you actually put all the direction, the oxygen, the pressure to just crystallize, what do I need to act on? Do I want to increase my PVR? Do I want to increase my SVR? Do I want to decrease my PVR? Do I want to decrease my SVR? Do I want to increase flow? To increase flow, do I need to give inotropy? What could be the problem with my different inotropes? What are the things I don't want to start because my baby's tachycardic maybe? I see my diastolic pressure is very low. That's a problem for my coronary perfusion. How do I adjust this? And then reassess. Did the management suggestion make sense? Did it improve the patient? Do I still need these agents? Do I stop it? Do I continue it, et cetera, et cetera? Okay?
Mm-hmm.
So that's it. Thank you so much. I'm going to stop the
Thank
recording
you.
here.